So, good morning, everyone. Thank you for kind invitation. I'm very honored to be here among our ophthalmologist colleagues and non-ophthalmologist colleagues. My presentation is about monovision cataract surgery, and I'm trying to present this presentation very simple, just like a practical guide for trainees and registrar, and not having the diagrams, and just very straightforward, straight to the point. So how we can apply monovision cataract surgery, what are the benefits, what's the principle, and some pearls basically. I would like to disclose that I have no financial interest to declare. Let's address the presentation with this question: what is monovision? Basically, usually I would like to have my presentation as an interactive session, but I think I will go straight to the explanation. And if you want to ask me questions, just please do so as we go along, because that would be possibly more helpful. My presentation would not be very long, so I think we can integrate our questions and answers as we go through the presentation. So I've got a very concrete thinking, and for me everything is about black and white, and I try to have a very strict and straight to the point what we need to do. So simplistically, monovision is we correct dominant eye for distance and non-dominant eye for near, as simple as that. So monovision is a misnomer. Basically, we are not separating two eyes, are not monovision. Actually, it is binocular vision. And this binocular vision is better just to say blended vision. Refractive surgeons are, I think, a bit more advanced in that way, that are saying that blended vision, laser vision correction, for example, that's the best way. Oh, okay, thank you. Don't have that much diagram, but anyway, thanks very much. It's very helpful. Right. Okay. Monovision is not only used in cataract surgery. Monovision can be used in any refractive surgery practices. For example, contact lens fitting, contact lens fitting, and the laser vision correction. Even glasses, some people are using glasses as monovision, and they are very useful. It is very common practice, and is an alternative to presbyopia correcting intraocular lens. So it's another option. It's not replacement, but it's another option how we look at it because of a lot of reasons that we are discussing later. So it is widely used. And actually, in the past, when we didn't have very many good presbyopic correcting intraocular lenses, monovision was more popular. So possibly, I'm not sure why it's jumping. Anyway, it's not me. So it was according to the and based on what studies we are looking at. In ESCRS in 2016, 43% of cataract surgeons, they used IOL monovision already. In the United States, based on the American Society of Cataract and Refractive Surgery, the figure was 27%. The reason is possibly in the United States that they used to use presbyopic intraocular lens more common than the other countries. So the number possibly is roughly half of the Europeans or international surgeons because of this reason, because presbyopic intraocular lens, such as multifocal lenses, and nowadays EDOF, extended depth of focus, were more common. So why pseudophakic monovision? So pseudophakic monovision is quite effective option. So provides patient satisfaction, high spectacle independence, good stereo vision. Stereo vision is going to be compromised, but overall, if we choose the patients properly and deliver a specific type of monovision, we are talking about the types of monovision, then the patient should have good. I don't know why he's jumping. Just so compared to presbyopia correcting intraocular lens, the rate of exchange and explantation is much less because we are using monofocal lens. The dysphotopsia is less, the contrast sensitivity is better, so the patient is more satisfied, so that we don't need to exchange the lenses as such. So these are the problems with the EDOF lenses. I'm sure that you're familiar with this term, EDOF, extended depth of focus lenses, like VVT and Synergy, this type of lenses. So still we are having this problem with dysphotopsia if we are not considering the factors such as copper angles, alpha angles, pupil size, and stereopsis for the patient. So I'm sure that you are familiar with these alpha and copper angles that are very important in refractive surgery, including the monofocal intraocular lens for the cataract surgery and EDOF. So we know that the copper angles is the angle between pupillary axis and the visual and optical axis, and if it's more than 5 degrees, then we are going to have problems with the dysphotopsia. Pupil size obviously is very important. If you got the very large mesopic pupil, then we get a lot of dysphotopsia at night time. Neuroadaptation in monofocal cataract surgery is much easier to achieve compared to multifocal lenses and EDOF. So I would tell you some words how we choose the patient that can adopt monovision better than the others. That's easy to adopt, and of course low cost. And the mono intraocular lenses in United Kingdom is around, the most expensive one is about 60-70 pounds. So if I'm right with the exchange rate, in euros is about 80 euros, whereas we have the intraocular lens from EDOF lenses and multifocal lens around 300-350 pounds. So it is very cost-effective way to provide a spectacle independence. I don't think there is any doubt about it, but just we need to choose the patients correctly. And of course, the contrast sensitivity is an issue with presbyopic correcting intraocular lens. We know that this is very important to tell the patient that the contrast sensitivity is going to be compromised. When we have, for example, multifocal lenses or EDOF lenses, when the lens is going to process few images and the light is going to be split in different focal range, therefore the patient doesn't have the bright images. So the contrast sensitivity is an issue. Whereas in monovision cataract surgery, we got the monofocal lens and the contrast sensitivity is not that, it's very simple. So always in my consultation, I tell the patient that, look, you need to have bright, if you go for a la carte with your beloved wife or husband, then don't expect that you can read the menu without, for example, without the glasses, or if you ask somebody to just lighten up the room. Anyway, so then why don't we use the monovision cataract surgery? If it's that good, why not everybody uses that? So obviously there are some limitations with cataract surgery and with any surgery. So we are dealing with the human tissues, with the living human tissues, and we cannot guarantee the outcome. It depends on the patient's recovery, surgical induced astigmatism by the surgeon, and also where the lens is sitting in the capsular bag, how is sitting in the capsular bag. So we cannot predict if the lens is going to have the tilt, or basically these sort of things can cause dysphotopsia. Always, again, I tell the patient that with all the advanced science and technology, and we are going to be looked after from A to Z by us, but we don't know if we take the lens, which is about 4 to 5 millimeter thick in thickness, and then replace it with the intraocular lens. It's a plastic lens, it's only open 5 millimeter or 1 millimeter. I cannot guarantee that this lens, where is sitting. Of course, we got the formula, like a Kane formula, and Olsen formula, that we can predict the effective lens position and provide the best outcome. But still, there are a lot of variables. So we cannot guarantee that this is going to give you the best outcome. It's very single. The single most important factor is we need to tell the patient that the distance vision of near vision is not going to be as good as distance vision of the distance vision. Basically, if we have the near eye, basically the non-dominant eye is set for near, and the dominant eye set for distance, and the patient after surgery says, oh, my near vision eye, which is the non-dominant eye, cannot see the distance. They need to know that this is the way. This is the way we are going to monovision. That's about monovision. But still, we need to highlight it, because imagine that you were dealing with a lay person, and these things should be documented, explained. The chair time is very important. The cataract surgery now is the most difficult consultation, in my opinion, in the world, because the options are significant. I don't have this luxury in the NHS. But in my private practice, my consultation for cataract surgery is an hour and a half by myself, not with the nurse. So we explain about all this to the patients. 1 session, 2 sessions, and all is going to be explained, documented, and just illustrated in the notes. Spectacle freedom. Again, spectacle freedom is not 100% guaranteed. Patients should understand they need to wear glasses, for example, for nighttime driving, because the contrast, again, is going to be affected, not as much as the EDOF lenses and multifocal lenses, but still in a rainy, dark day at nighttime, they need to use glasses. So, and also for a long episode of long small print reading for a long time, if they are going to use use their eyes, they need to have spectacles to read. So this is another restriction. Fine stereo vision definitely is going to be compromised. There is no doubt. If the patient is a pilot, is a surgeon, particularly an eye surgeon, needs doing the microsurgery, stereo vision is compromised, no doubt about it. If the patient is a professional golfer and is going to be, just again, it's not going to be a good stereo vision. So this needs to be selected and discussed with the patient, and not to use the monovision cataract surgery. So, but gross stereo vision is intact. So stairs, curbs, we can have that depth of focus, so there isn't any problem with that. However, we can overcome these problems by applying different type of monovision. I'm going to explain about the types of the monovision in a few minutes' time. So, how to plan pseudophakic monovision? Like any other practice, any types of practice, we need to have a good history, taking the history from the patient, what they are looking for. Occupation is very important, as I mentioned. If there's somebody needs to have an engineer working on the machinery, or is a billiard player needs to have a stereo vision, golfer, or pilot. We need to find out what their occupation is, what their needs are. So know your patient, because every patient is different. You need to customize your approach. It's not, just like a monofocal intraocular lens. We target 0. We put these lenses. We need to. It's an art. Now, cataract surgery is a refractive surgery. It's not the 20th century. The 21st century, patients coming with the wealth of information, and they ask you to deliver the service. So you need to know the patient. The cataract surgery now is massive problem in United Kingdom. This medical legal problem that patients, NHS doesn't have that much time to explain about this, and the patients coming out, oh, you didn't tell me about multifocal lens, you didn't tell me about monovision. And this is a legal issue in United Kingdom. We need to know our patients very well, their needs, hobbies, lifestyle. Is a truck driver. I recently had a policeman as a private patient, a VIP driver. He was 52. He was the driver of very high-ranked politicians and so on, and he wanted to have aesthetical independence. And he had a nighttime driving around 40,000 miles per year, very, very demanding. So we need to know the patient. Otherwise, it's not a line of factory just to make all the patients similar to each other anyway. So, and the preference of a spectacle. If the patient does not mind wearing glasses, is not going to appreciate your work, your skills to provide spectacle independence. Because this patient is, if the patient says, all my life I've been wearing glasses, and without glasses I feel naked, I've heard about this, so why do we do that? So just forget about monovision. You don't need to do that. So personality is very important, is our minefield in refractive surgery. If the patient is coming with the personality very demanding, very perfectionist, is a red flag. I'm not saying that we shouldn't do that. We should be very, very careful and not to do differently, because I don't think I do different types of surgery from somebody who is very perfectionist or not. But we need to explain. We need to explain. Chair time is very, very important. So now we know our patients. We know that we are going to do that. How to deliver this? I'm sorry about this. Just it's jumping back and forth. I don't know why. So investigations, biometry. Biometry is the most important test that we should be very careful. Again, biometry is the major source of errors. I don't know that, I know that we have got a room, but in our practice in NHS, biometry is done by nurses. With all respects, they are doing the good job, but this is the ophthalmologist, this is the doctor to realize that this biometry is correct. So we got the criteria, 5 or 6 criteria when we should do it again out of the biometry. The difference between case, difference between the axial length. We need to match it with the refractive. For example, if the patient has got the axial length of 29, but the refractive errors is only -1, is not correct, because 29, axial 29, we are expecting at -5, -6. These sort of things. We need to be biometry. We need to do biometry. Again, when I have control out of NHS, I do 4 biometries and over 2 sessions. So to make sure that these biometries are very consistent, and I'm doing it myself. I don't let anybody do that. So when the biometries are consistent, particularly for astigmatism and case and so on, I'll do it. And if they are consistent, then I would go forward. And if they are not consistent, I do it again. I treat the eyes. the dry eyes, anything that can cause this biometry errors. And then of course comprehensive slit lamp examination to find AMD, the diabetic retinopathy, diabetic macular edema, epiretinal membrane. There are three tests that usually we don't do it, but for these cases we should do cover and uncover tests to find out about strabismus, phoria, and obviously tropia. If we miss that and then we do the monovision, because of the anisometropia, this anisometropia is going to compromise the eye movements and is a burden to extraocular movement system. Therefore, the patient may develop diplopia. So it's very important we find out about the phoria and tropia. To find out about dominant eye is very easy. To find the dominant eye, one test that I use in my practice is a triangle test. So you stretch out your arms, or if you stretch out your arms and look at the top letter on the Snellen chart, and then with both eyes open, you can see it. When you close one eye, and if that letter disappears, that eye is non-dominant. And if it stays there, it's dominant. This is the triangle test. You can do the thumb test. You can do the pointing test. Or you can do the hole in the card test that, make a hole about 1 inch and put it on the target, the distant target, and bring it towards your eyes. It's still, you're naturally bringing that part over the dominant eye because you're going to maintain your gaze or your sight on that object. That eye is dominant eye. Plus lens mimic test, that would give the patient an opportunity to find out about monovision. We put plus 150, plus 1.50 on the non-dominant eye and simulate the monovision. If the patient likes it, that's fine, we go ahead. The better test is contact lens fitting. If we do the monovision contact lens, we ask the optician to provide monovision contact lenses for the patient, and the patient would do the daily activities, shopping, walking, driving, reading, and if they like it, the feedback is important. If the feedback says that, okay, I can cope with all these and new adaptation is there, is easy, we go ahead with the monovision cataract surgery. This is the investigation of choice, in my opinion, because the patient has got enough opportunity to practice this monovision, whereas just plus 150 test is not going to give is an instantaneous feeling about monovision, and may not be good for shopping, the driving, and so on. But it is a good start, because if the patient doesn't like plus 1.50, so there is no point to go further. So for contact lens trial, there are some limitations because patient possibly because of the age, they don't want to go through the hassle of having the monovision contact lenses, or if the vision is very poor, if the patient has got very dense cataract, so they cannot have monovision contact lens, they cannot feel that this is monovision, they cannot appreciate it. So we don't know in these cases, if a very dense cataract or the patient has got traumatic eye with a low vision, I personally would not proceed with monovision, because I think that we are gambling with the patient's eye, and I don't like that. So contact lens trial is not essential, but is reasonable and is recommended if you can convince the patient, and that would give you very high level of confidence that this patient is good for monovision. And I think we should do that. The other thing is the stereopsis. Stereopsis is important. If the patient doesn't have good stereopsis, that we know that from our residency, the Titmus test, the NTNO test with the red and green spectacles, Lang test, and the Frisbee test with all these shapes and so on. Usually we see it only in the exams because they are usually are being used by the orthoptist, but it's a good test if you do it. I don't do it on a regular basis, but sometimes if the patient has got a history of strabismus and so on, I would ask the orthoptist to do it for me. So we talked about the how to select the distance or near vision eye. So that dominance test and the triangle test and the hole in the card test. There are a few other factors we should consider. For example, if the patient has got very high myopic eye, we should not take that eye for the for the dominant eye. We should take it for non-dominant eye. Or if the patient has got a history of monovision for any reason, for example, the patient is contact lens wearer, monovision contact lens wearer, regardless of the dominance test that we are doing, we should keep the same arrangement. So we don't reverse it because there is very, very obvious reason. For example, the patient has got right eye, dominant eye, and left eye, non-dominant. But for any reason, developing cataract, for example, the eye has been reversed. The non-dominant eye becomes reversed. This is just, as soon as we take the lens out, so it's going to reverse to do whatever it was because the brain preferred that. So that's very, very simple. If the patients are used to the monovision contact lens and my right eye is dominant eye, listen to the patient. Again, taking history is very important as we discussed. So we talked about the weaker eye, which is I refer to the eye with the more refractive errors, more astigmatic eye. So these eyes should be set for near. Ocular comorbidities. Some surgeons, if the patient is very highly motivated, they go for near vision. They set that eye with the ocular comorbidity for near. Again, this is a controversy. If there's a ocular comorbidities and the vision is not good, most surgeons would not go for the monovision because we are not achieving the spectacle independence. I'll mention this one about this ocular comorbidities later. So this is very important slide to me. So possibly you've heard about different types of monovision. Monovision, we need to customize our approach. And there is no consensus about the classification of monovision. But one of the classification is this classification. So mini monovision, when we defocus eye or the anisometry is between -0.50 to -0.75. This is very popular, it's gaining popularity in the world because we are using digital device more and more, and this provides good intermediate and far vision, but we don't need to, nowadays we don't use the reading vision too much. We are all of us on the screen or distance, so this is a good one. And that provides good contrast, sensitivity, and stereopsis. It's good for truck driver, taxi driver using GPS, or for people are on the social media using the screen. So modest monovision, the majority of monovision nowadays are they are falling into that group. So defocus by -1 to -150. So this is a sweet spot for spectacle independence. Is considered physiologic because allowing fusion rather than suppression. So the patient has got good stereopsis, good contrast sensitivity, and at the same time there's good near vision and far vision too. But they should be told that they need to have glasses if they need to read for a long time, or if they are going to again drive in a rainy and dark day. So it's not completely spectacle independent. Full monovision. This is good for people, they need to have very excellent reading vision without glasses. It provides fantastic reading vision. For example, if somebody, an elderly with a hobby of reading books, doing puzzles, and wants to be spectacle independent in the house and watching television, but not driving at night time and so on. So this is a good vision for near and intermediate. So this is the good one. So again, but definitely because of the high anisometropia difference between two eyes, stereopsis is going to be affected. So again, we have to choose the patients correctly. So you see that we customize our monovision depending on the patient's lifestyle and occupation. If, for example, we can discuss about a patient is a truck driver or is a pilot or is an engineer or retired. So we need to listen to the patient and find the best monovision for the patients. So when we don't use the pseudophakic monovision, tropia or significant phoria, they are dissociated vision. So the two eyes are not associated. So if we use monovision with the load of anisometropia, we are dissociating the two eyes. So there is a risk of diplopia. So we are talking about this later again. So it's very important, as we say, about cover and non-cover test. We should identify significant phoria. Sometimes even borderline phoria can be a contraindication, but is relative contraindication. Any history of double vision, prism usage, strabismus surgery, this is just a minefield and the red flags, and we should not do that because the balance is very fragile. As soon as we put the patients under the strain of anisometropia with two eyes, a difference of -2, -150, then two eyes are dissociating and then we are in trouble. The double vision patient came to do the aesthetical dependency, you have to do a strabismus surgery on this patient, it's not good. So, and as we mentioned about the ocular comorbidities, if the patient has got the bad vision because of the AMD, because of the glaucoma, diabetic macular edema, these patients are not going to achieve this aesthetical independence. It's better just to go for monofocal intraocular lens, put in the patient's vision at distance and give them a magnifier, as simple as that. Just you need to be very frank with the patient that you need to have glasses and you need to have the magnifiers and so on. Any condition that affecting the extraocular movements can cause problem with in the monovision, pseudophakic monovision. Again, with the same principle, because we are dissociating two eyes and we're putting pressure on the extraocular movements balance. Therefore, very easy to think of the conditions that affecting extraocular muscles in systemic conditions, Parkinson's, Graves, multiple sclerosis, and myasthenia gravis. So these ones are contraindications. Many-year disease. Many-year disease is very common. I mean, it's better just to say that it's not very uncommon. Professor Conti possibly knows better than I do about Meniere's, definitely. Meniere's is one of the most common vestibular disorders, and the vestibular systems includes inner ear and brain, and provides a very simple, it's a very simple approach for me, the definition of the Meniere's disease. And they provide sensory information to control the balance and eye movements. So if we put again the patients with two different refractive errors, with different refractive errors, again, we can burden, it would be a burden or could be a burden to extraocular movements, and worsening of Meniere's disease could be related to this monovision, pseudophakic monovision. So we avoid that this condition. So amblyopia and monovision. Amblyopia and monofixation syndrome usually coexist. So we are already in the back foot for this condition. So it's better not to use the patients with amblyopia because the spectacle independence would not be achieved, and non-dominant eye is already suppressed in amblyopic patients. So again, the two eyes are not going to work with each other, and we are, to start, we are in the back foot. So for amblyopic patients, it's better not to do this. Just I'm aware of the time limitation. I'm just going to go very fast. Astigmatism and monovision. Astigmatism is not the contraindication as long as we correct them correctly. So the understanding of astigmatism is very important, and the cutoff point nowadays is getting less and less. Used to be 1 and 50, now it becomes 0.75 now, is even 0.5. Depending on if the patient has got with the rule astigmatism or against the rule astigmatism. I hope that you understand or you know this concept, because if you don't know this concept, you shouldn't do cataract surgery with the astigmatism. It's very, very important. So very simplistic, because I think this is my aim to deliver this presentation very simple. That's the way I learn. If the patient has got with the rule astigmatism, so the back float has got always against the rule astigmatism. So we are overestimating with the rule astigmatism. If the patient has got against the rule, so we are underestimating the astigmatism. Therefore, if we are having a patient with, for example, you're going to do mini monovision, a patient expects a good vision for distance, and the patient has got the against the rule astigmatism for 0.5. You need to correct it, because 0.5 is, we are going to underestimating it. But if the patient has got the, for example, with the rule astigmatism 0.75 or 1, we can get away with it. So these are very important. We understand the astigmatism and correct it accordingly. So with the rule, against the rule, we are privileged nowadays that most online calculators, they calculate with the rule astigmatism against the rule and with the rule astigmatism for us. But understanding this is very important, because the majority of biometer, they are not calculating astigmatism considering the posterior corneal astigmatism. So if you see that the patient has got with the rule astigmatism or against the rule astigmatism, we need to understand when you should use these online calculators. Okay, so this is about astigmatism. Cross monovision. Cross monovision is the other way around. So we keep the non-dominant eye at for distance and dominant eye for near. So why we do that? Because this is all we've discussed, that we need to find the other way around. So there are some circumstances that we are not achieving the target. For example, for non-dominant eye, we start with non-dominant eye and we target -1 because we want to do moderate monovision. But unfortunately, because it happens to a lot of us, that it has achieved, for example, less refractive errors, -0.25. So the eye was planned for near, now is seeing distance. So either we should abandon monovision pseudophakic and go for the next eye, the other eye for distance, or we do the cross monovision. We can do that. We can only if we do all the tests, basically covered test, non-covered test. There's no FORIA, because if you do the cross monovision, patient may develop diplopia, which is called fixation switch diplopia, basically alternating the fixation between dominant and non-dominant eye. And the more we dissociate them with the higher refractive errors, for example, 2 diopters, the more this can happen. So if we do that, go for the lower possible anisometropia, not more than 1.5. So modified or hybrid monovision contact lens. Some people, they use one eye as a with monofocal lens and the other one with the multifocal or EDOF lenses. It is a controversy practice, but people are using them. And the benefit is when one eye, there's a monofocal lens, is set for the distance, and the other eye, which is the near vision eye, non-dominant eye, we set it for EDOF or multifocal lenses, then the patient have near vision, which is very good, and intermediate and distance. So basically, we are giving this advantage to the patient that the near vision eye or non-dominant eye seeing more than near. I hope that it is easy to understand. Yeah. So EDOF and hybrid. The only problem here is your two eyes are competing with each other, and neuroadaptation in the eye which is implanted with the hybrid and multifocal lens may have difficulties to cope with this concept of basically multiple images, because the right, for example, one of the eyes, the right eye is for distance and monofocal, and the other one is hybrid, the other one is multifocal, and there are different images. So the eye or the brain prefers the eye with the clear image, so goes for the monofocal lens. Are you with me? So the patients may have difficulties. So what's happening? I don't know if you've seen multifocal lenses patients or EDOF patients. When you ask them for the first few weeks, when you see them, when you ask them to, for example, to read the distance, and then suddenly, if you say that, okay, read my reading type, they may say, oh my God, he's not going to read it. What's wrong with the lens? But actually, the brain tries to find the image that they have to see, because multiple images are processed. So this is called neuroadaptation. The longer the brain, the sooner the brain find these images. So this competition between two eyes, if one eye is monofocal and the other one is EDOF, is going to continue. This battle between two eyes is going to continue. Neuroadaptation is taking longer, or may not happen at all. So some patients may say that I don't like two eyes differently. We were in the American Academy of Ophthalmology, and I was a resident 2008, 2009, and one of these breakfast meeting, and the guy was, I don't need to mention the name. In 2008, he had done more than 1,000 multifocal lenses. And I was listening to him, and he was saying that never mix and match the lenses. And it still is stuck in my mind because of this reason. And I'm not sure if the modified or hybrid monovision, I haven't tried it, but because I've seen it in literature, I thought to put it up. But just take it with a pinch of salt. I don't think it's a good idea, but it's good to know about this option. So just with a few, 2 or 3 last slides. So now I hope that you know about monovision, and just let's start the practice of monovision. How we choose the patients. I mean, like any other things, any sport or anything, you want to have an easy start. So easiest start is finding the best candidates. So find an easygoing patient, nice one, and the patient is highly motivated, is not perfectionist, so, and have got a very healthy eyes. So you don't need to worry about a little bit of epiretinal membrane, macular degeneration, glaucoma is being affected. So, and it is a gift. If the patient has already been using monovision contact lens, it's much easier. It's much easier. So we say that, okay, half the battle has been won already. So these are the red flag patients. I'm not saying that you should not do it. I'm saying that for the first few patients, don't do it. This is a hard work. So if the patient is happy to wear glasses, why we do that? So the patient is not going to appreciate. Low myopic patients already has got a very good vision. They don't need to wear glasses for close up, and then got a reasonable vision for intermediate and distance. So they're not going to just adopt monovision as such. Any ocular morbidity, systemic conditions affecting the extraocular muscles should not be, and obviously perfectionist and demanding patient. So according to one of the articles, I'm just going to go very fast through the last 2 slides. So these are the statistics. Only 1% of patients who require, actually it's very optimistic survey, only 1% of patients does not to wear glasses at all. But as you can see, is a 42% of patients are completely spectacle independent, which is a good number. And 1/3 of patients, just they need to have night glasses for nighttime driving, which is reasonable. We know about that because of the contrast sensitivity. So this is the last slide. The key takeaways. So success keys, or as we know, then knowing the patient selection. Refractive surgery is all about doing the right surgery to the right patient. And if you don't do that, then you're in trouble. If is not the line of production, so everybody going through the clinic, particularly in the private practice, so you want to have the high conversion rate, everybody makes money for you. It's not like that. It's not a business. It's just to find the right patient and do the right operation. And if you cannot do that, you cannot deliver that type of operation, and the outcome is not good, forget about that surgery and suggest another type of surgery, or don't do it, because this is very important. Every cataract surgery, you should discuss no surgery option with the patient. Wearing glasses. Have you tried glasses? No spectacles should be in every consent that the alternative has been discussed with the patient. If you don't do that, consent is invalid. As simple as that, from medical legal point of view. So we need to, nowadays a lot of digital consent form in the United Kingdom has got very nicely formatted. All the alternatives has been discussed, no cataract, and then just is a press of button, and then everything is populated. But obviously you need to prove that the patient has read and understood it. So preoperative testing again is very important, and as we say, correct, precise biometry is the main issue here. Achieving the refractive target again is depending on the accurate preoperative testing, avoiding contraindications. So in this era, everybody uses digital devices, and because of the global economic strain everywhere in every country, I think pseudophakic monovision is a reliable, cost-effective, and very straightforward option if you choose the patient correctly for presbyopic correction, rather than using very expensive lenses with a lot of preoperative testing and consideration, which is not easy for non-refractive surgeon to understand the EDOF and multifocal lenses. This option is straightforward, and I think every cataract surgeon should think of this option and should be included in the process of discussing the cataract surgery with the patient. Thanks very much for your time. So, is there any question?